thank you so much for joining. In terms of bits and pieces, so I'm Mark Tighe. I'm a consultant paediatrician at University Hospitals Dorset, down here in Poole, and Deputy Care Group Medical Director for Women and Children. And I've got Holly here ably helping, and if there's a major IT failure, it's entirely my fault, not hers. But she may throw me a life belt. Essentially, the aim of this conversation over the next hour, and very welcome for people to eat their sandwiches, interrupt, stick their hands up, all of those bits and pieces. But the aim of this presentation is hopefully to give colleagues a bit more of an understanding about how to manage abdominal pain in childhood, which can be terrifying because there can be an awful lot of emotion attached to it, and also constipation. So for those people who want to turn on the cameras, they're very welcome to. For those people who don't, then that's absolutely fine, and I'll carry on if that's okay.
Yep.
So in terms of the objectives, it's divided into two areas. So I'm going to talk about chronic abdominal pain in childhood, and particularly focusing on the differences between organic and non-organic causes of abdominal pain, and then we'll chat about constipation in the second half. So it's going to be game of two halves. First case, just to kind of get everybody into the swing of it, if that sounded all right. Patient that I saw, 12-year-old boy, or that you may well see as clinicians, 12-year-old boy with a 4-month history of regular, non-specific abdominal pain, loose stools, including occasionally at night time, no reported fever, and otherwise well. That's the sort of thumbnail that you get. By a show of hands, would there be anybody at this stage who would reassure them and send them home with safety advice? If anybody's able to just stick up their hands on Teams. Would there be anybody who'd do some baseline bloods and potentially a fecal calprotectin? Oh, good. Yeah, thanks, Catherine. Brilliant. And so getting 4 hands there. Fantastic. Anybody at this stage who'd go, do you know what? Bang it in the direction of the specialists. Refer for outpatient paediatric review. And by a show of hands, if that's number 3. And then number 4 would be refer from an inpatient paediatric review. That's straight up to the hospital, same day, once you've got past switchboard and spoken to somebody, if that is indeed the same day, then, you know, but it doesn't look like there's many takers for that. So it sounds like a bit of a consensus for baseline bloods, calprotectin, and see where we go. Okay, I'm going to come back to that. I think the initial scenario had the first person saying on the first appointment was saying reassure them and send them home with safety net advice. And what then happened is they came back 4 weeks later with still significant ongoing regular pain, daily loose stools, and actually when you dug further, because he's 12 and he doesn't really want to talk about it, he's actually sitting on the toilet several times in the day and 2 or 3 times at night. He's now started to notice occasional blood mixed in with the stools. He's intermittently getting a low-grade fever and doesn't have any signs of an upper respiratory tract infection. He's had a weight loss of 2.5 kilos since you saw him originally, and he's also getting mouth ulcers. So I think for this patient, we're probably thinking there's a bit more mischief going on there. At this point, again, grateful for a show of hands, but would you reassure and send home with safety net advice? Oh, brilliant. Yeah, Wiggy is thinking very, very ahead in this. Would you think of baseline bloods and a stool sample? Show of hands. Would you refer for outpatient paediatric review? Thanks, Daniel, Sarah, and Kate. Starting to get a bit more popular, that one. Would you refer for inpatient paediatric review? And a couple of hands still staying up for there. It's a bit more concerning, and there's a few more red flags. I think it's fair to say inflammatory bowel disease in pediatrics is rare. It's 10 per 100,000. However, a quarter of all patients diagnosed with inflammatory bowel disease are diagnosed under the age of 18. And particularly in their teenage years, it seems to be that metabolic stress of having to have 2,000 to 2,500 calories a day, plus potentially the dietary choices that our teenagers may choose, may be a bit more likely to precipitate them into inflammatory bowel disease. But the youngest patient I have is actually 18 months. So you can get very early onset inflammatory bowel disease. That's a bit more likely to have a genetic predisposition. If you've got a family member who's got inflammatory bowel disease, your risk goes from 10 per 100,000 up to about 1 to 5%. So it is a big multiplier of risk. And the classical features such as diarrhea, abdominal pain, reduced appetite, blood in stool, weight loss. Try and explore a bit more in the history about the abdominal pain. Is it still present, and is it still waking them up at night, which is a bit more of a red flag. In terms of the blood in the stool, is it mixed in? Again, weight loss, just try and work out whether the child is trying to manage their bowel symptoms by eating less, or whether there's other reasons there for the weight loss. But also have a think about delay in puberty, potentially getting an idea of parental height centiles to understand whether they're growing but below their parental height centiles, and also when mum and dad went through puberty. Think about poor growth velocity also being a concerning feature of inflammatory bowel disease, as well as mouth ulcers and perianal changes. Extraintestinal symptoms such as joint aches and joint swelling, eye pain and redness, and temperature are concerning red flags as well. And when you initially see them, definitely think about full blood count, particularly looking at platelets, using these LFTs, particularly looking at albumin and CRP, a fecal calprotectin. I wouldn't worry so much about those calprotectins that are between 50 to 250, in the sort of borderline range. Once you're getting more above 250, that is a bit more interesting. Above 500, just send them in terms of outpatient investigations. But if they are significantly anemic, significant weight loss that's compromising them, then consider having a chat to the registrar on call, potentially in terms of either inpatient review on the assessment unit or a rapid referral outpatients. All of these patients will need endoscopy and biopsy under general anaesthetic, and some of them get MRIs and ultrasound as well. They're managed with 5-ASA derivatives and steroids, and some are treated with elemental enteral diet, particularly Crohn's, as opposed to ulcerative colitis, where that doesn't work as well. And then they might have maintenance immunosuppression, for example, with azathioprine, particularly if they've had a couple of flares in the year, or biologics such as infliximab and adalimumab. Happy days. And there's some useful resources there as well. Next case, 2-year-old boy with daily abdominal pain and bloating, loose stools, fussy eater, reflux as a baby, though that had settled, but certainly the loose stools have occurred since 6 months of age, and the weight has fallen across from the 50th centile to the 9th centile over the preceding 2 months. No reported fever and had previously breastfed well. What would you do? Again, show of hands really in terms of reassuring and sending them home with safety net advice. Baseline blood tests including TTG and IgA, and you can probably see where this is going. Couple of hands. Yeah,
I like that option.
Loads of hands there. Thank you very much. That's very exciting. Send a fecal calprotectin. Slightly trick one, this one, and the reason I threw that in is because calprotectins aren't validated in under 4s, so you're much more likely to have a slightly higher normal range with this. And then you've got refer for outpatient paediatric review or discuss with on-call paediatrician. Yeah, I think probably bloods and see where we go. I think a good choice. And yes, this patient had a TTG IgA of above 128. And celiac disease, estimated prevalence in the UK 1 in 100. It's an enteropathy caused by gluten and associated proteins in children with a genetic predisposition in terms of HLA DQ2 and 8. It is an important cause of mild abdominal pain and bloating in children under the age of 3, because I can't tell you terribly much about it, but actually these children can be diagnosed any age from 6 months onwards when they've started gluten. It does seem as though there's a preceding viral hit and then a mounting immune response. So children who've previously had negative celiac screens can subsequently be positive, though generally a celiac screen that's negative, unless there's new symptoms, it's good for at least 2 or 3 years. Definitely do investigations on gluten. So make sure that they're having at least 2 slices of bread a day, plus biscuits, cakes, pasta, pizza bases, that kind of thing. And the blood test is TTG IgA and a total IgA or anti-endomysial antibodies. Some places, if the patient has a low total IgA, they'll go on and do TTG IgG as standard, and that's still a pretty good test. Both of those blood tests are 95% sensitive and specific. TTG IgG just slightly lower, but still pretty reliable. But the gold standard is duodenal biopsy, and I'll come on to chat about the new ESPGHAN guidelines in 2020, which is if you're if you're symptomatic, do the first line tests, and if the TTG IgA is above 10 times the upper limit of normal, you can either do a second EMA, a second sample for anti-endomysial antibodies, or you can ask the lab to process EMA on the first sample and diagnose them with celiac disease. They don't need a biopsy, and you can just get them straight onto a gluten-free diet, signpost them to Celiac UK, and go from there. Obviously, involving your hospital in that decision making can be is really important, but sometimes you can just get that done on an advice and guidance. However, don't stop the gluten until because if the TTG is raised but less than 10 times the upper limit of normal, as they're going to need a biopsy, as there's still a false positive rate. Again, if they're IgA deficient, IgG tests positive. If it's less than 10 times the upper limit of normal, they'll need a biopsy. If it's above 10 times the upper limit of normal, they can start a gluten-free diet with the discussion of your secondary care providers. Hope that's useful. It has made a massive difference to the waiting times that children start. And say that again.
I want to give it to the pharmacy.
Oh, pharmacy. Yeah. So gluten-free products. Yes, gluten-free products are available on prescription in some areas at a rapidly reducing rate. We're still in Dorset trying to make sure that our children have gluten-free bread and flour, but anything more than that, I don't think is generally on the ACBS system anymore. I think it's really useful, and because children can't go and buy their own gluten-free products. So we do see a reduced adherence to gluten-free diets if patients can't get it on prescription. So the longer we can keep that for families, particularly those families where they're entitled to additional benefits or free school meals, it is really helpful. The next case is probably where we're going to focus a little bit for the next 5 or 10 minutes. So I'm going to present a 14-year-old girl with daily central abdominal pain since September, very fine over the school holidays, intermittent loose stools, occasional nausea, no weight loss, no other systemic symptoms, pain relieved by opening the bowels, no reported fever and no blood in the stools. And the reason mum is with you is that school attendance is now 45%. Show of hands, reasonably similar to what we were doing before. Do we reassure and discharge with safety net advice? Baseline bloods, including TTG, total IgA review, potentially calprotectin in there as well. Any hands for that? Yeah. starting to get a little cluster of support for that. I think that's a really good idea. Treat with a course of metronidazole and review. Probably less useful in this circumstance, though I'll touch upon a certain circumstance where you can use metronidazole. And then lactose-free diet. That's echoing silence there. Okay, so the things to consider in terms of managing. So this is going to be a little one with, sorry, to 14-year-old functional pain. So functional pain is common in school-aged children and is about 10 to 15% of the population, though this can be the really difficult group to manage in primary care. It is poorly understood. There's a multitude of factors implicated in causation, both physical in terms of recent viral illness, and then psychological in terms of stress in the family, geographical move, poverty, difficulties at school or at home, and patients often have vague symptoms. Investigations often bring a low yield of organic disease, and probably only 5% of children will have a diagnosis of organic disease. And there's some good studies showing that if you did, bloods, baseline blood tests, including TTG, IgA, inflammatory markers, and you also did a calprotectin. If those are normal, that's probably got as good sensitive pickup as investigating all the children with the bloods, stool tests, MRI scan, and endoscopy. These children are not suffering from a shortage of investigations. It's just obviously their pain is caused by not a functional pathology. And the treatment strategies are varied, often subjective, and low evidence based to support them. And basically, this category of children, the diagnostic criteria has been there since about the 60s, with more than 3 episodes of abdominal pain in children over a greater than 3-month period that's severe enough to affect daily activity. So it's not your short-lasting abdominal pain that lasts for 2 or 3 weeks. The pain is occurring on a daily or weekly basis, stops them doing with stuff that they would want to do, such as school. And it would be fair to say that if you looked at children in your playground with abdominal pain, the scores in those children with abdominal pain in the playground and those children who are coming to your clinic, the scores, symptom severity scores, are pretty much identical. But you've got to ask, why is the child in front of you when so many children have just as significant abdominal pain and never present to a doctor? And it may be a little bit about how the family's functioning and how the pain is impacting on their day-to-day routine. And what I'd probably say is that divide it down into 4 areas, and it's really important to give a label. Just it's not a disease, it probably isn't enough, because families then go, oh, the doctor doesn't know what's going on. And I'd probably say persistent or recurrent epigastric pain or discomfort that's associated with nausea and worse on eating, we would call functional dyspepsia. Functional abdominal pain is persistent or recurrent periumbilical pain or discomfort with no change with eating or defecating, is your functional abdominal pain. Irritable bowel syndrome is persistent or recurrent suprapubic pain or discomfort, but where the bowel habit alters with pain, such as diarrhea, and so you get either more diarrhea or more constipation when the pain is on the increase. Abdominal pain and cyclical vomiting is a different category. These are sudden onset, come on out of the blue, intense periumbilical pain, can be associated with very significant vomiting, lasts for maybe either more than an hour or 2, increasing up to a couple of days, but in between time they are very well. They go back to normal straight away, and they're kind of counting down the 48 hours until they can get back to school. And 80% of them have a family history of migraines or travel sickness. And as they get a bit older, they may start to say, oh, I get headaches more. And as they go through puberty, it'll move to a more migraine type phenomenon. Okay. So the principles for managing it are to do reassuring investigations, saying that I think they're going to be reassuring, and then give a diagnosis and stop doing investigations. Seek and address the family's concerns. Are they thinking that it's cancer? And it doesn't, but it and by addressing those, that the pain is still real, but there's not an underlying disease. You can offer an explanation for functional pain, and I'll go on to how to deliver that in a second. Support with resources, and reassure that things usually get a bit better with time, but may fluctuate with further stressors in the future. Evidence for treatments are not brilliant, and distraction is probably more effective, as well as anxiety, explaining the brain-gut axis, and giving a detailed explanation that gives parents enough information that they can manage their child through a future crisis. Think about associated anxiety and think about psychological input, and sometimes asking children, what are their top 3 worries, following the sort of Maudsley quote of that which has no vent in tears makes other organs weep. You can see functional abdominal pain or other issues such as headache, limb ache, significant tiredness, all following the same model when there's an underpinning difficulty that the child's trying to deal with. Allergy testing, such as food allergy panels, not helpful in the absence of IgE-mediated symptoms, though keeping a food diary is really useful. And if there's a strong family history, you could try a exclusion diet just for 2 weeks and then re-challenge, conscious that we're not too far away from Christmas, so try not to impact on a child's enjoyment over the Christmas holidays with a food exclusion. But it's just worth planning in mind that parents may be enthusiastic for it, but the child may be much less enthusiastic. But the emphasis is on maintaining function and limiting impact. So what you can't do after something like this is say, you're going to be fine, get back into school full time. These children may have had quite a long time off school, and grading them back into education, grading them back to activity may take a little bit longer, and sort of going, for a couple of hours a day and then building up by, say, an hour every week, you may then get back to much more school attendance than if you go back in and the child gives it a really good go and then comes home at the school day and then is shattered for 2 or 3 days, and then you sort of have this sort of relapsing, remitting cycle of school attendance. And follow them up until the symptoms resolve or improve, and reinvestigate if there's significant red flags. Because children with about 1% of children with chronic abdominal pain may evolve into an organic disease. And the sort of explanation as to how to sell it is that the pain is the child's response to biological factors, but it's definitely influenced by temperament. So the child's developing personality, but the family around them, and the school environment. If there's a significant family history of functional abdominal pain or significant back pain, especially if it's preventing them from working, that can be a bit of a concerning feature. But sometimes you can bring it out in your explanation and say, look, there are other people who are dealing with significant pain in terms of irritable bowel syndrome or very painful periods, and yet they are still managing to get into work, still able to do some activities, though they don't feel 100%. And the really key bit is that although this will take a huge amount of time in your GP, your very busy GP lists, is that if parents buy into this, 90% of children get better. If parents don't buy into it, less than 10% of children get better. And so the options you can go for are, in terms of pitching the explanation to the families that you're with. Some families want a very basic explanation of, people get butterflies in the tummy before, a big interview or a first date. Sometimes people perceive that as pain, and that can, be really sore and really difficult to live with, but it will get better. The second thing will be visceral hypersensitivity, and then I'll talk about visceral hypersensitivity and pain thresholds. Marvi, can I just finish doing this tiny bit and then I'll come to your question? Would that be okay?
Yeah.
Fab. So hypersensitivity. So if you want to go into a little bit more detail, you probably all remember the diagram on your left from medical school. The hypersensitivity of the autonomic nervous system is definitely demonstrable at the enteric level, the spinal level, and cerebral level in children who are coping with significant pain. You get upregulation of receptors and pain neurotransmitters such as substance P, so that even normal bowel activity, even normal bowel peristalsis, it can be painful, and this can be made worse if there's a lot of stress and worry about what the potential causes of the pain are. But understanding the pain, normalizing it, and using that language can definitely down-regulate that those pain thresholds. And you'll probably be used to explaining peristalsis as rhythmic phasic contractions squeezing all the way through the bowel, but about 5 times a day you get these giant waves of contraction that last for about half an hour, run the length of the bowel and can be significantly painful. So when you look at if you imagine your bowel activity on a graph over where the x-axis is time, you've got your threshold of awareness there, and then the pain threshold is that more solid dotted line there. So you've got your normal rhythmic phasic contractions there, and you've got your giant migrating contraction that doesn't penetrate the pain threshold, and a child is happy. I think we all know what happens with gastroenteritis. You get a much bigger wave of contraction. It's really uncomfortable for all of us, and we're all really unhappy. However, when you've got that stress, you can have that drop in the threshold, and that's where even normal activity can be perceived with pain. But if you explain and understand it over time, that pain threshold goes up, and the child can live with this better. And I've found that this is a model that really works well with certain groups of parents in terms of our lawyers or accountants. Sorry, Marvi, can I bring you in at that point, if that's okay?
Yeah, actually, thank you so much. Quite informative. A few things which usually we are diagnosing the constipation also in these groups, and we are doing X-rays and just looking for some reason to explain, and radiology, especially ultrasounds, are also we are doing unnecessarily. So just to satisfy the parents. So how much role of radiology and constipation diagnosis in these situations?
Yeah, that's a really good question. I talk about constipation just a little bit further along, but in terms of constipation, in terms of abdominal pain, definitely steer away from try and steer away from MRIs if you can. And X-rays are a really poor way of looking at the bowel. An ultrasound does come with a consultant attached to the end of it. So that parents who are awake at 2 and 3 in the morning, worried that their child has cancer, an ultrasound can be quite useful. Yeah, so you can often code your ultrasound requests of looking for bowel inflammation, and that can be that certainly the families I've used, it really helps them to springboard into something else. Constipation, I'd probably say the bowel. If you've got irritable bowel and you've got poo in there, it can be a bit of an irritant, but you can spend quite a lot of time upping and downing laxatives. And some of the laxatives cause a bit more cramps. So it's just managing that with an understanding of your overall bowel neurophysiology may help your explanation, if you see what I mean. But I'll talk a bit more about constipation in a second. Does that sound okay? Right. So next bit, abdominal migraine. So that fourth group that we're talking about, definitely think about dietary modification, increased fluid intake. Some evidence about trigger foods, but it's not brilliant. And if you've got an obvious trigger food, then cut it out. But I wouldn't necessarily go for a complete dietary exclusion. Analgesia such as paracetamol and non-steroidals can be useful for very intermittent abdominal pain. Triptans, definitely a good evidence base in adults. In children, it's pretty poor. They don't really like the sort of flushing that you can get with it. But if you find a parent really benefits from it, it's worth a trial. Probably better evidence bases for propranolol or pizotofen. Propranolol, they both sort of stabilize blood vessels and can be really useful as migraine treatments. Pizotofen also helps children to sleep. Right, so summary for that bit would be definitely think about recurrent abdominal pain as a common cause of presentations, recognize the red flag symptoms, explore the psychosocial causative factors, and use one-stop targeted investigations to exclude organic disease, and then good luck with the explanations. And that's the Wessex Healthier Together recurrent abdominal pain pathway. So constipation in children, aim of this is to review it, talk about common causes and talk about common treatments. Again, your enthusiasm and ability to sell this is going to be key as clinician colleagues. So if we take a 2-year-old boy who's had hard, painful poos and abdominal distension, grumpy for 6 months, frequent soiling, so he runs behind the sofa to strain, a poor appetite and increased distress before opening his bowels. His observations are really settled, and he's growing along the 25th centile, and his abdominal examination shows mild distension and palpable stool in the left iliac fossa, and you've checked his spine and his lower limb reflexes, and these are normal. What investigations would you what investigations would you do at this stage? We've got none. Any hands up for none? Excellent. Thanks, Lynn. Thanks, Victoria. Thanks, Sarah. What about an abdominal X-ray? Oh, Lynn's got her hand. Lynn, was that a question or was? Happy days. In terms of abdominal X-ray, any takers for the abdominal X-ray? It's not brilliant. There's lots of time that you can muse at the screen looking at the various distribution of poo. NICE have said that it's not a very good test. Baseline bloods including a celiac screen. Any hands up for that? Plus or minus a calprotectin, because you could do both. No hands at this stage. I think there's a bit of a conversation perhaps with your families about the role of investigations. Obviously, parents can be much more enthusiastic about investigations than their children, and there is an option to sort of start treatment and see how it goes, but try not to let it go too long with a child being on medications without thinking of investigations, because it's always tricky if you then diagnose them with celiac disease further down the line. It may not have caused the constipation, but it just creates heartache all round. So I'll probably think about investigations in the first kind of 3 to 6 months of managing this. So what would you do next? Would you reassure and encourage increased fluid? Start oral Movicol and give an information sheet? Wessex Healthier Together. Or would you reassure and increase the dietary fibre intake? Any hands up for 1? Any hands up for 2? Yep. Bit of love for that. Oh, I love the thumbs up. Yes. And then reassure and increase dietary fiber intake. Any enthusiasm for that? Maybe useful. Yeah, there's possibly something that you could do with that. It's easier to advise dietary fiber intake than to give it to a toddler, but there we go. So in terms of toddler constipation, often related to toilet training, and there's a bit of a conversation as to with your families as to whether the kind of little one was ready for toilet training, or whether the parents had 2 weeks off work to try and get it sorted. And perhaps you could sort of, is the child indicating that they're doing a wee or that they want to do a poo, or and that can help get you in the right place. Definitely go for a positive, fun approach to toileting. Think about, a simple kind of poo dance, a reward chart, this is and sometimes other rewards that help motivate the child. And they've got to be instant. This young man is 2. His attention span will have moved on if you say, oh, we'll go to the shops in 5-10 minutes. That won't work. So yeah, have a sort of little drawer of treats or rewards ready to go. Definitely make parents part of the solution. There is nothing harder than in your in your GP appointments and mine than parents plonking themselves down and going, my child's still constipated, what can you do to sort it out? So definitely ask them. And once you go around the, what about the rewards, what about the fluid, what about the fiber, and then check about the efficacy of medicines, you've generally found something there to work on. 95% of patients have functional constipation without an underlying disease. So again, investigations have a low threshold, a low pickup rate, and it's important to say that at the beginning. And it is really common. It affects up to a third of children, depending on which community surveillance studies you look at, and it can last at least 3 months. Definite red flags to pick up and ask about: failure to thrive or significant weight loss, delayed passage of meconium, so not pooing in the first 48 hours, persistently abnormal bowel habits since birth, so in the first 28 days, blood or mucus mixed in with the stools, or change of bowels with introduction of cow's milk are red flags. And if you're not sure, do have a look back, because on many of the GP records or health visitor records, there's a lovely health visitor note, on their first appointment at day 10 or day 14 saying opening bowels normally, and that really helps reassure you away from Hirschsprung's disease. Definite modifiable factors. We talked about fluids. We talked about foods. Brown bread. If you've got a child who's absolutely against brown bread, think about best of both. Fruit and veg, whole wheat cereals. Sometimes ask parents, if you give them sweet corn, how long does it take the sweet corn to emerge? Day 5 or onwards sort of suggests either, markedly slow gut transit or kind of cements your enthusiasm about laxatives. Encourage physical activity. Definitely think about swimming. Definitely think about minding time on electronic devices. I'll talk about that in a second. Think about position on the potty or on the toilet. If you think about toilet from a 2-year-old's point of view, it's a hole that their bottom doesn't particularly sit in terribly well. They may not even know what the toilet is for. Parents may close the door just for 5 minutes of peace. So having the child in with you, experiencing what it's like to be for toileting, and work on their understanding. There are some apps such as Poo Goes to Pooland and other things like that that you can use just to promote enthusiasm and fun. Next one, 3-year-old boy, persistent constipation despite trying your 3rd laxative. But when you go back, you actually find that they've passed meconium on day 5 and that they subsequently open their bowels weekly with associated straining. Not much in the way of overflow. Growth fallen across from the 25th to the 2nd centile for height and weight, and on examination, the young person has a very distended abdomen with palpable stool through the abdomen. And you think, this is a bit unusual, and you refer up to rapid referral, and they do some investigations and also do an abdominal x-ray, and there it's reasonably obvious that you've got a gas-filled abdomen but actually not much air in the rectum, and this is a young man who was subsequently diagnosed with Hirschsprung's. So definitely think about those red flags that we were talking about. Also bear in mind, sometimes there's a switch from breastfeeding to bottle feeding, and if that's been a little bit complex, babies can be a little bit dehydrated, and that can affect the stool output. Also have a think about your children who have coexisting medical problems. Down syndrome or cerebral palsy may have more constipation due to hypotonic gut or dysmotile gut, impaired mobility, and impaired understanding and ability to tell their parents. There is a sort of degree of that with sort of the hypermobile Ehlers-Danlos type profile, and you may need sort of slightly more stimulant laxatives in that group as well. Hirschsprung's disease, as you probably remember, absence of your ganglion cells from the internal anal sphincter proximally, which fails to relax and causes a functional obstruction. Most of the time it's picked up in the neonatal period, but up to 20% patients present late with an intractable constipation or failure to thrive. the features are obvious on examination, included a distended examination, and what's described as a squirt blast sign. I've seen it a couple of times. It's exactly what it says. In terms of digital rectal examination, probably not recommended in primary care, as it can. And I've only done in terms of my clinical practice as a consultant for 5 years, for 15 years. I've probably done about 5 or 6. You don't really need to do them, and generally only on babies. If you're that concerned, they're probably going to need to go to secondary care anyway. Occurs in about 1 in 5,000 live births, slightly increased incidence with patients who've had neuroblastoma and in patients with Down syndrome, and it's more common in boys. And of those patients who've previously had treatment for Hirschsprung's, just bear in mind if they present with, if they're really hot and feeling unwell with abdominal pain, think about enterocolitis even in the treated population. This young man underwent a defunctioning ileostomy and then end-to-end anastomosis and did really well. But if you've got a normal bowel pattern in the first month, if parents come to you saying, what about a rectal biopsy, I'd be really reassuring from that point of view. Southampton did a really good audit where they looked at 10 years worth of practice in terms of rectal biopsies, and of those children who and found no cases of Hirschsprung's in those children who'd had normal bowel habit in the first month. So last clinical case, and then we'll chat about laxatives a little bit. So this is a 10-year-old boy with hard, painful stools and abdominal distension since starting school, hates Movicol, loves Minecraft. His eye contact isn't brilliant, and he quite likes a beige diet, and there's a family history of eczema. On examination, his temperature and heart rate and respiratory rate were fine. He's growing along the 25th centile. His abdominal examination again showed quite a lot of palpable stool in the left iliac fossa, and he again had normal spinal exam and normal lower limb reflexes. What would you do next? Reassure and encourage increased fluid or dietary intake. Any hands for that? Restart Movicol. Just, get parents to just do it a bit better, and give an information sheet. Any takers for that? Or add in Senna and discuss toilet paths and separate toilet at school. Few nods from even Holly's nodding at that one, and a few thumbs. Sorry, especially Holly is nodding for that one. Yes, excellent. Entirely agree with option 3. However, just have a think about the impact of neurodiversity. There is sort of that impaired brain-gut communication, and helping children understand the signals of their bowel can be really tricky. It's worth saying to these families that it's taken quite a long time to get like this. It will take probably just as long to sort out, to manage their expectations as to how long it can take to sort. Think about toilet timing, so encouraging them to sit on the toilet after breakfast, lunch and dinner for 5 minutes, and if there's local continence provision, think about additional help for continence needs, especially where there's a cost of living pressure. But working on the family's motivation and understanding is key. How does the little one indicate, or the young man indicate, that they are needing to go to the loo? Is there a smell? Sometimes parents get pretty cross about the accident, but often it's the just before the accident, and trying to work out, does the accident happen, in the morning before going to school? Does it happen in the morning at school, in which case you could have thought about going to the loo either before getting to school or at break time? If it happens in the afternoon, think about going to the toilet at lunchtime. Often there's a bit of an accident because the child gets home, gets straight on their gaming console, and then games solidly to try and get over school for a good couple of hours, and then there's sort of an accident around that time, and trying to encourage them to sit on the toilet after getting home from school can be quite good. There's a large proportion of children who, as you probably anticipate when you were at school, just hold on all day grimly, hoping that they don't have to go to the school toilet, and trying to give them access to a separate toilet should they wish can be really useful. Think about the taste of medicines. There's think about switching them from liquids to tablets, which can be quite useful, especially in this age. Think about sometimes hospitals have access to a pill school to help with switching over to tablets. There's also the Kids Meds project. If you look at that online, helps you give parents the ability to do a sort of how to get onto tablets type thing, and you'll probably find some cost savings there for that'll make your practice managers really happy. In terms of stimulants, Senna and Bisoconol are the stimulant tablets that are really useful. It would be fair to say that if you're starting off, stimulant laxatives, it's not fair to send children to school for the first sort of couple of weeks if you're trying to do this and they've really had a really difficult time. Just maybe ask for them to have either started at the weekend or started at half term or during school holiday. 10% need laxatives for more than a year. Also, family history of eczema. Thank you so much, Holly. Much appreciated for dropping that in the chat. Have a think about a dairy-free diet in those children where it can be refractory and they've got eczema or family history. It can be revolutionary, and just cut out dairy for 2 weeks in this situation and see what happens. There's some really useful resources on constipation. Think about the ERIC website as well. For older children, it does have a watch that you can get off the ERIC website that buzzes, so that it's not parents going, "You've got to sit on the toilet." No, I don't want to sit on the toilet. They get away from that kind of dynamic. And there's some really good, nice information in terms of clinical guideline 99. And there's this sort of Wessex Healthier Together flow sheet, and I think we're at a point. I tried to leave a little bit so that we could perhaps chat about any questions, because obviously there'll be significant cases that you might want to bring, or things that you remember that you want to contribute. So I'll probably throw it open to questions at that point, and if people want to turn on their cameras, that would also be, at this point, you're very, very welcome to, but obviously please keep them off if you prefer, or we can look in the chat. Yeah. I mean, this cohort is a really tricky group, and like I say, you have got the support of secondary care. It's just you may find more secondary care referrals are getting turned around, particularly for recurrent abdominal pain with, well, this is what it sounds like. Can you give some advice and see how it goes? Okay, Lynn, you've got a brilliant question there about how do we manage piles in under fives. So I probably just want to make sure that that there's an associated history of straining, because it's a bit more unusual to get it in that age group. We do have a paediatric surgeon, and given that you're at Shaw Partnership, that'll be Angela Brent here at University Hospitals Dorset. But to do a small surgical operation, I think if there's just a single sort of skin tag at the 12 o'clock position, that's probably reasonably normal, a sentinel tag. But yes, the other thing is perianal Crohn's. If you've got lots of skin tags and piles starting to emerge there, that may be the important point to trigger a referral. Happy days here. Are you? Excellent. Any other scenarios? I guess the other bit that we sometimes have is have a think. What some different secondary care areas may have something different, but sometimes there's like I say, continence nurse support. The other thing that I tend to do is I tend to admit, if there's a really tricky situation where I'm really not making any progress, I tend to admit children to hospital for 2 weeks, and we do a sort of supported toileting regime to help parents understand the signals of their children. What it definitely isn't is drop your child off and then pick them up in 2 weeks with the continence issue sorted. It's getting them in and part of the discussion. But we tend to get dietitian review, play input for younger children, and psychological input for older children, and it can make a massive difference. And then what you can say to families is, when the if and when the child goes backwards, you go, well, we when you put in all the resources and you do all the simple things really well, we can get your child going really well. So let's see if we can get back there, if you see what I mean. Go for it. So good questions here. Can we start pizotifen in primary care? Absolutely. So I would probably recommend starting off at 0.5 milligrams at night for 2 weeks, and then go up to 1 milligram at night if there's no improvement. If you're not winning there, I haven't had many children who improve on the 1.5 milligram regime. So and particularly in older children, you might want to think of propranolol at that point. Thanks, Wergi. Essentially, I'd focus this talk on more chronic abdominal pain rather than acute abdominal pain, in terms of the difference between appendicitis and mesenteric adenitis. Do endocrine causes cause abdominal pain? Yes. So a high calcium level, sort of Mohs stones and abdominal groans is the old school mnemonic to help remember it. But yeah, and obviously new presentations of diabetes can definitely cause abdominal pain. So particularly if there's a change in respiratory pattern, think about doing a blood sugar. Also think about a urinary tract infection. I guess acute appendicitis, it's picking out those children who have acute appendiceal inflammation from those children who've got mesenteric adenitis and they've had a preceding viral prodrome for the previous 48 hours. They've got red throat, they've got big lymph nodes, but there's a bit of an overlap, and as you probably know, clinical examination only helps you differentiate 50% of the cases. So sometimes that conversation with hospital to help you, because then you get a set of bloods and a CRP plus minus an ultrasound, and then you can be a bit more definitive. Sophie, please can you talk about disimpaction regime? Yeah, very much so. So what we normally do for a disimpaction, so if a child's, I sort of talked about the slightly more complex cases here because I knew your time was limited, so I wanted to give you a bit of extra added value. The disimpaction regime is nicely laid out in the NICE guidance, but you'd start off on 2 sachets of Movicol, and then 48 hours 4 sachets, then 6 sachets, then 8 sachets, and the flow sheet that we had here could probably help if I can get it to go backwards. Yes. So your maximum 8 a day if you're less than 11, or 12 a day if you're between 12 and 17, until the stools are watery and clear brown. Definitely don't send them to school if you're doing a disimpaction regime. And then once it's watery, halve the dose and continue. Then coming down to probably where their maintenance dose is needed. You might get to a point where you are still having recurrent accidents though, and if the abdominal examination is very reassuring they're having recurrent accidents, that might be the time to think stimulants, if you see what I mean. And Senna's got all Senna, bisacodyl, Movicol, they're all safe into the long term. So although parents will say, oh, I wonder if it causes a lazy bowel, actually I talk to parents about it being like asthma, and inhalers moving your lungs into a normal range of function in asthma, and laxative move your bowel into a normal range of functioning there. Sarah's brilliant question: is there a way of making Movicol more palatable for kids? I think they've withdrawn the sort of Movichoc option where they make in terms of chocolate preparation, but as long I think sometimes so that's the neurodiversity thing as well. I think there's probably something a little bit about the age of the child. Some children you can smuggle it in, some children are sort of expecting it from their parents, and it can put them off drinking. So probably having that differentiation between you know, this is medicine and have it, you know, with a small amount of fluids. Sometimes you can mix it with other drinks such as Fanta or Coke or lemonade if you're struggling as well. You know, obviously the dentists there will ask us to come off the sugary drinks as quickly as possible, but that may also be an option. The other thing is, like I say, that was part of the scenario, is, you know, is there a role for tablets? Can you crush the tablets, maybe mix it in with ice cream, a sort of Senna McFlurry type option, you know, just to make it a little bit more easy to manage. And Tracy, I do agree with your ERIC website fact sheet to give parents about a disimpaction regime. Yes, it is. You know, there's a huge amount of useful information there. Any other questions? I think the other thing is try and get parents not to stop the laxatives too soon. There can be a temptation to do that. Many of our teenagers are quite happy to bin off laxatives as soon as they don't need it, and often they just stop taking it and don't tell their parents. Which is fine. And many of our children, when they become teenagers, that greater bodily awareness really helps them with their bowel function. Plus also they realize that the Wi-Fi works in the toilet, and then they disappear in there with their phones, and that helps their bowels as well. Yeah. Happy days. Well, if that's okay, I might then give you 5 minutes back on your day. But Holly, is there a sort of feedback sheet thing that we could send round? I really appreciate you dropping your feedback in the chat, but if there's anything that you can do, you know, to let Holly know that the thing is that the funding for this hasn't completely been secured. So the more funding we can have to make other topics like this and to show to our commissioners that it is a really important thing to do, you know, it just keeps the wheels turning, as you know.
Yeah, a feedback form will be sent out this afternoon for everyone to fill out. So, and there's also a plea in there for topics for next year. If there's anything you'd be really interested in hearing about, stick it in there.
Particularly, you know, you guys do such a fabulous job in primary care. What are the things that you want paediatricians to tell you about to help you know, keep children in, you know, in primary care, or refer the ones that you need to?